Hi, my name is Peter. I'm an emergency physician resident in Stockholm. And this is my lecture for the Danish Emergency Medicine Conference 9 about the dizzy patient in the ED. This is an extended lecture as opposed to the shorter lecture that I gave at the conference. I have a disclaimer. I am a proponent of the Hintz test in the ED, and I've written blogs about this topic, and I've also written a chapter in the Danish Emergency Medicine book about this topic, for which I receive a symbolic sum of money. The disposition of this lecture is the following. I want to first of all talk about the Hintz test, why we should do it and how. Then I will come into a intermezzo where I will talk about EPM and some of the articles related to the Hintz test, and then I will go on to talk about BPPV, as this is a topic that I think is not taught enough in the emergency department, and I think we can help our patients hugely by knowing a few tricks. But first of all, let's talk about the Hintz test and why and how. Okay, so why do we need to do the Hintz test? And I will jump back and forth between the Hintz Plus and the Hintz test. The Hintz Plus test has not been validated to my knowledge, and the only difference between the Hintz Plus and the Hintz test is that it includes the test of hearing, but I'll come into that later. For all practical purposes, you can interchange the Hintz test with the Hintz Plus test in this lecture. So if we have our dizzy patient who will end up with a stroke diagnosis, then it becomes clear that there are kind of two groups when you examine these patients. There's the group that has the overt neurological problems. These are usually medial brainstem infarctions, where you have motor components that are quite obvious. If anyone has ever read about the rule of 4, then you can part up the brainstem infarctions into the medial and the lateral ones, and you can the medial ones are much more obvious because they have motor deficits. The lateral ones can be hard to pick up, and these are exactly the ones that might be missed on a normal neurological exam. A lot of them even have very subtle neurological findings that we might only be able to find by using the Hintz test, or at least rule in by using the Hintz test. And these are usually, as I said, lateral medullary ICA or pica strokes, or maybe cerebellar strokes from time to time as well. If you want to know more about this in detail, I recommend the original article about the rule of 4 by Gates. It can be found on Life in the Fast Lane if you Google search rule of 4. And I've also gone into this topic in other lectures that can be found on my YouTube channel. We have already gone through some of these topics in our blog, the akutmedicinen.dk. We have our Hintz exam video, and we have my blog in Danish called Dizzyness in the Emergency Department, or Svimmelhed på akutmodtagelsen. And then we have done a evidence-based analysis of the Kattah study, which I will also be doing a bit more superficially in this lecture. But please go into our homepage and check these out if you want to know more. Okay, so this is like the central figure of the Hintz test. The Hintz test is better. It has better sensitivity than an MRI, and the MRI test is only 80 to 85% sensitive when it's used within the 48-hour window, which means a lot of the patients that we see in the emergency department will not be able to be ruled out by a negative MRI. So we need another test for these things, and that's where the Hintz test come into the picture. And some of the studies that I will mention, they have a greater sensitivity when compared to the MRI. But there are some caveats that we will also go into. But this, on the face of it, looks great. Okay, so when you just look at these figures, a lot of emergency physicians, a lot of physicians in general, having heard about the Hintz test, they will jump right in and say, well, here we have a great tool for this extremely difficult patient population with dizziness, which is hugely heterogeneous. And then we can just use this to differentiate between whether this is a central cause or a peripheral cause. And as I've shown this picture, many doctors use this Hintz test wrong. They use it as if you can use it on all patients with dizziness. And that's where a lot of the critique of the Hintz test has arisen from. Because we want that test. We want that great test that can just differentiate bedside between central and peripheral cause. But as Dmitriev in an retrospective review has seen that around 97% of ED physicians not necessarily being taught the Hintz exam in the right way, but having read about it and used it in their clinic, they use it in the wrong patient population. And that is harmful, as we will go into in short. But that doesn't mean that we shouldn't use the Hintz test, is my opinion. And we just need to learn about it and learn which patients we need to use it for. And if we do that, then I think it's an incredible useful tool. So that's what I wanted to teach you here in the next couple of slides. Okay, so just to hammer this home, point intended, the Hintz test is not this test for everything that we for all dizzy patients that we see in the ED, because the mountain of undifferentiated patients in the ED, which amounts to around, depending on the study, 1 to 3% of all patients being seen in the ED, it's a hugely heterogeneous group, and the ones that have indications for Hintz are quite small. And another misnomer or another misapplied way of thinking about the Hintz test is that that it's a test for all the strokes or all the central causes, and that is not correct either. There are definitely a lot of patients in this mountain of undifferentiated patients that have serious causes, medical or central neurological, that the Hintz test will not necessarily tease out. So the Hintz test is one test, but we still need to do a thorough neuro exam, especially focusing on the posterior part of the brain and the symptoms that might arise from these areas. We also need a lot of other tests, which I will get into. Especially history is important. So we have a toolbox for our dizzy patients, within which the Hintz test is one of the great tools, just another of the great tools that we need to know how to apply and which patients we need to apply it for. So what are the indications then for the Hintz test? And this is, I mean, I like to do the bottom line up front. If you don't take anything else away from this lecture about the Hintz test, then this is the essential slide. I want you to take away that the patients that we use the HINTS test for are the patient that is constantly dizzy at baseline, meaning that when they've been lying still for a few minutes, they're still not they're still dizzy, and this is important. They have spontaneous nystagmus, meaning that when they are just looking straight ahead, they will have a nystagmus, or they have gaze-evoked nystagmus, meaning that when you ask them to look left or right, they will and nystagmus is induced. And again, it's important that these patients has been lying still for a few minutes before you assess these features. This is also what we call the acute vestibular syndrome. There's some terminology confusion there sometimes, but in general, the AVS, or the acute vestibular syndrome, is thought of as a constant dizziness that at baseline, meaning that when you're lying still, it's no better or worse than when you're supine. It's not triggered by any specific movement, but it may be worsened by shaking your head as any kind of dizziness. That is not specific. And you, depending on the terminology, sometimes within the AVS definition, you will have nystagmus, but that is not necessary in all the definitions, and that's where the terminology sometimes becomes problematic. But what you need to know is that the patients that you will have to examine with the HINTS test is the patient with acute onset dizziness that is constant at baseline, and who has either a spontaneous or a gaze-evoked nystagmus. That is all I want you to know. Okay, let's go into a bit more detail than that. So who do we want to test, and then how do we test it? So who do we want to test for with this HINTS tests? Well, first of all, we have this mountain of undifferentiated patients that are dizzy in our ED, and we know that some of them we do need to use the HINTS test for, but how do we tease that out? Well, we need to sort some of them. We need to filter some of them away from. We need to filter some of them before we arrive at this patient group with the monosymptomatic dizzy patients. And the filtering process is like this. The dizziness, what we might call dizziness plus, if they have other overt symptoms, meaning that if they have overt neurological deficits, especially from the posterior vascular area of the brain, then you will need to go with a stroke algorithm, or depending on if you think it's MS or anything else, then you will go with that. But you will go with a central cause, which usually will be a stroke algorithm. That doesn't mean that the HINTS test cannot be applied sometimes to these patients, but it just means that you cannot rule out this patient. And in most of the studies that we are going to discuss, the HINTS test exclusion criteria in these studies is exactly these neurological symptoms. I want to just make it obvious that, well, these overt motor and sensory deficits are important to test for. These are not the hard patients to assess. Sensory-wise, sometimes you will need to test for pain stimuli, because that is some of the lateral medullary brainstem symptoms. So it's not just touching; it's also pain. The moderate to severe dysmetria and truncal ataxia are really important, and as we will see in a bit, the patients can be lightly ataxic. That's all right. But if they are severely, when you do a finger test, or you do other dysmetric tests, especially if they're if they have truncal ataxia, meaning that if they sit and they have their arms crossed around their chest and they cannot sit without assistance, then it's important to treat them as a stroke, no matter what the HINS test tells you. Then you have the more specific signs of posterior vascular strokes, like dysarthria, diplopia, dysphagia. And this depends on the stroke syndrome. There are other D's here as well. I haven't taken in all of them in this lecture, but these are just some of the examples. Then I highlight Horner syndrome as well, because if you have a dissection of either your vertebral artery or your internal carotid artery, then sometimes this is the only sign. And it's a sign that can be seen in 25 to 50% of patients with these vascular pathologies. So, and it's really subtle sometimes. So it's really important to have it in front of your mind to be able to diagnose these patients. So thorough neurological examination of the undifferentiated patient in the ED is important. Then this is also a very important criteria, that the patient cannot stand or sit or walk unassisted. And you can have a patient having a totally normal HINS test, HINS test showing peripheral pathology, but they cannot stand and they cannot sit unassisted. Then you would usually have to admit these patients, both because they're so dizzy that they cannot be at home, but also because there might be a stroke hiding underneath that. So this assessment of being able to sit unassisted and walk unassisted is important. They are allowed to be a bit wobbly, but they should be able to do it unassisted. And of course, you have to take into account that some patients can sit unassisted from baseline, and that's where it becomes complicated, and you have to do it on an individual level, see if they can see if they're much worse than their baseline or not. So that's where an older neurological examination in the charts is important to look up. Okay. Then you have some of the other red flags, and these are important to sort out as well. And these are usually these can be like syncope, dyspnea, or chest pain, which could indicate everything from ACS to dysarrhythmia to maybe a subarachnoid hemorrhage if it's a syncope with a headache. Also, you have to rule out your carotid artery dissections and vertebral artery dissections if you have someone with severe, with significant pain from their head or neck alongside dizziness. And this is especially important in the young population, of which I've seen a handful of strokes presenting like this. Then there's the thing about alcohol, and alcohol can obscure. Alcohol makes your test more noisy. There's a lot more false positives with alcohol, and usually I would be very careful about interpreting a test in the alcoholic intoxicated patients, as they will sometimes have central pattern nystagmus. So better be cautious about this patient group and err on the side of doing more than less, or at least not ruling out the patient just because they're alcoholic. Okay, it's important to know that this is a relatively small group of patients. It's not a lot of patients that we see. If we take the mountain of dizzy patients that will present like this and have these red flags, but these are important to pick out. And because the majority of dizzy patients don't necessarily have a neurological cause of their dizziness. The majority usually have a unspecific or medical condition, and that's where that's why it's important to keep a broad mind about these things. So, but if you don't find any of these, and as we will go through in a little bit, if you don't have any of the specific findings from these monosymptomatic dissipations, then usually the end of the algorithm is that this is an unspecific dizziness, where you need to think about medical conditions and other stuff. The medical conditions that I would encourage you to think about in the studies are things like anemia, hyponatremia, muscle wasting, and BPPV, which would be positional panic attack, vertigo. I think this is a Swedish term. I cannot remember the English term, but it is a anxiety-evoked dizziness, which is quite common. And then you have your medication side effects. So all of this, like all of your unbalance versus dizziness diagnoses are important. All of the patient needs to be assessed for these things as well, usually, because in the elderly, it doesn't matter what the cause is. A stroke might be just as serious, a medical condition might be just as serious in the elderly if they fall and have a hip fracture. So these are really important to think about. And in my opinion, whether or not you should look for these all the time, it depends on your setting and depends on how significant patient's symptoms are. And as I said, if you don't find any specific findings going through this algorithm or way of looking at your dizzy patient, if you don't find any of the findings here, and you don't find any of the HINTS findings or the hallpike findings or head roll test findings, then usually you will end up in this patient group, and usually this is the majority of patients being seen in an emergency department with dizziness, at least 40 or 50%. But when you have kind of screened your way through this high-risk patient group, then you will get to your monosymptomatic dizzy patient. And it's important when we say monosymptomatic that these are allowed to have, they're allowed to be a bit off balance and have a balance that is worse than usual. That is actually in some of the studies a criteria that they need to have some kind of imbalance, but it's not allowed to be like really severe. It's not allowed to be that they cannot stand unassisted. And sometimes you need to push your patient a bit because they are in a bad way. They're throwing up and they're really, really sick usually. And it's important to just as when you're assessing the knee, whether it's locked from pain reasons or mechanical reasons, you need to assess whether this apparent inability to stand or sit, whether this is due to them not being able to at all, or just that they're so nauseated that they cannot. And that's an important distinction that is not always easy to do. And again, you will hear me say this several times: err on the side of caution when you're in doubt with this, especially if you're an emergency physician. Then err on the side of caution. Contact your neurologist or your ENT doctor, depending on your setting, and admit the patient if you're in doubt. When we say that they're monosymptomatic, then they're allowed to have vomiting and nausea. And then this last piece of information is hearing loss and sometimes also tinnitus. And depending the hearing loss can sometimes be a central feature, but it depends on the context. If you have a patient with peripheral HINTS test pointing at a peripheral cause, and the only finding is that they have a hearing loss as well, then it is to be determined whether we should look at these as labyrinthitis or as a central AICA stroke. And in my experience, then usually the labyrinthitis patients have some kind of inflammation, which makes it more obviously labyrinthitis. But in general, we should be cautious when we hear that the patient, alongside with dizziness, has hearing loss, and that's what they integrated into the HINTS Plus test as well. Okay. Dr. Jonathan Etlow, who is one of the pioneers in this area the last couple of years, is an emergency physician in the United States, and he has, in one of his articles from 2018, done this algorithm with the acute onset dizziness patient. And what he quickly wants you to do is a nystagmus test, a test of skew, a head impulse test. But if nystagmus is negative, then you jump right down to your CNS signals and signs, and then you see if they can walk. And that is kind of what I just went through as well here. But he just puts the HINTS test above or first, where I put it as a thing that you will do after you've done your neurological exam. Okay, so what do I do when the patient comes into my emergency department? Well, this is a bed at our hospital, and usually we would do like this, or I would do like this. I would tell the patient to lie still, and this is really important. So some of my colleagues that are great at dizziness will sometimes put their hands on the patient's head so that they make sure that they stay still for these a couple of minutes. I write 5 or 10 minutes, but sometimes less is needed. But in general, they have to lie still for a few minutes. And while you have your hand on the head of the patient, then you can take your history and maybe do the basic neurological exam. Meanwhile, a nurse can put in a peripheral venous catheter, get some. It's not necessarily needed with all patients, but with a lot of patients, I do give them this package of ringers or sodium chloride with an antiemetic, and the antiemetic can be anything from Haldol to metoclopramide to ondansetron, depending on. But especially if they're outside any kind of thrombolysis window, then I don't need to assess them right away, and then I can easily just give them this. If I don't have time to be at the bedside for this amount for 5 or 10 minutes right away, then I will ask the nurse to give them this, and then I'll come back to them later. And this is also the time where you, depending on the history, you will ask for maybe a VVG, because you get the electrolyte disturbances there. You do get your hemoglobin, and you do also get to see if they have been vomiting severely, which might indicate that they need even more resuscitation with fluids. And you can also consider doing an ECG here. And then you can consider doing a Frenzel's test, and this is a Frenzel's test. It's in short, it's just a high-powered magnifying glass with two video screens, one for each eye. Here's for the left eye, and here's for the right eye. So you put on goggles. You put these goggles on the patient, and then you can see their eye movements, like zoomed in, and this is something that they use in a lot of the studies being done on HINTS, and it's usually a good thing, especially if you want to record or if you want to be more sensitive in your nystagmus assessment. Although I haven't seen studies saying that it's more sensitive, that is the theory anyway. If you don't have a Frenzel's test, then there are Barthol's glasses. There are other tests. There are other alternatives that has been come up with in the literature. One of the main features of the Frenzel's test, though, is that it will make the patient fixate, and it will increase your chance of seeing the nystagmus that you need to see. And some physicians are using paper, making the patient look through a paper as if they're looking at the wall behind them to get this kind of feature without the Frenzel's test. There are different methods. At our hospital, we do use a Frenzel's test, and it's quite easy to learn, and it's quite easy to maneuver, and it doesn't take much more time. So I do not know the price of these, but I would think that it wouldn't be impossible for most emergency departments to have one of these things. Okay. While you're standing here at the patient's bedside, you do take your history and neurological exam. Your neurological exam will focus on the features that we just talked about, making sure that you look for Horner syndrome, which is subtle, and some of the other subtle findings, especially your dysmetric tests, and your if the patient is all right with it, you can do a thorough exam while you're just sitting there. And making sure that they don't move their head in that time. When you get to the neurological part of the exam where you actually need to move the patient's head, then those things I will wait to assess, because you need to assess the head while it is lying still with the Frenzel. Okay. While you're listening to the history, you will listen for two specific questions. And these are, the first one is it better when you're lying still? And then can it be triggered by movement? And it's important to say that triggered is a very important word here. It's not getting worse. Imagine that you have dizziness at baseline. If you're dizzy at baseline, meaning that when you're just lying in bed, and when you get up, then you become a bit more dizzy. That is not a trigger. That's just dizziness getting a bit worse when you're moving. When we think about if it's triggered, triggered dizziness is at baseline you're not that dizzy. You're either not dizzy at all, or you're just a bit dizzy. So after lying in bed 5 or 10 minutes, then they're not dizzy at all, or just a bit dizzy, but not comparable to their dizziness when it's peaking. Then, if you move them, then it goes from 0 to 100% in a few seconds. That's a triggered response. That the movement has triggered the dizziness. Okay, so that is important to distinguish between those two. But these are the two questions, and there are different other algorithms, but and it's not like the other questions like duration of symptoms and so on. It's not important. You will notice those as well. There are different mnemonics that Dr. Ohle has come up with. For instance, the titrate. That's the titrate way of asking. But these are like some of the central questions for you to assess what kind of test you want to do now. The other questions, like duration of symptoms, is just something that is icing on the cake, I would say. Okay, so now you have your monosymptomatic dizzy patient. And your monosymptomatic dizzy patient, just to recap, is the patient that didn't have any neurological features at all when you did your screening exam. You will have to assess afterwards whether they can stand and sit unassisted, because you cannot do that now while you're holding their head and wanting them to stay quiet. Stay still. And what you're doing is that now you're listening for these two important questions that I just posed in the last slide. you're listening for them because you asked a broad question in the beginning so that the patient can tell their story. And so you can make this matrix 2x2 matrix here when you get the answer to these two questions. And either the patient thinks that the dizziness is constant, meaning that it's not better or worse when you're lying still. It's the same. There's no major difference whether they're standing or they're not, and whether they're being lying still for a few minutes or not. And the other one is whether or not it's triggered. And and the ones that are not triggered, we call those spontaneous. And in this way, you have 4, but actually just 3 important dizziness syndromes. The first one would be the spontaneous AVS. You don't usually call it spontaneous AVS. You just call it AVS implied that is spontaneous. You have your triggered episodic vestibular syndrome, which is characterized by, well, it's episodic, meaning that it comes and goes. But it comes and goes with a specific trigger. So it's better when you're lying still, and it's triggered by movement. And then you have your spontaneous EVS, your spontaneous episodic vestibular syndrome, meaning that you have someone who's dizzy and it comes and goes without any specific trigger. So it can be when they're sitting or standing, or it can come on any time of the day. But it's episodic and it's self-limiting. And these patients, you would, for each of these categories, and the reason why it might be important to put patients into these 3 categories is that there are specific syndromes or specific diagnoses that are hiding behind these categories, and there are different tests that you want to do on each of these categories. So, for instance, the AVS, well, 5 or 10% of these patients might have stroke. The rest will usually have vestibular neuritis or a vestibular migraine or something like that. With the tEVS, they will, like, where they are, the dizziness is triggered by a specific trigger, like most often movement. They will usually have BPPV or sometimes orthostatism. And then you have this group, the spontaneous EVS, and they were not usually, but they can have arrhythmias. They might have TIAs, and that's a whole, that's a huge discussion going into how we could diagnose a episodic or spontaneous episodic vestibular syndrome with a TIA. That's hugely complicated, and in my opinion, there is not a lot of good literature on this. So it's on an individual patient-to-patient basis. But in general, it's very rare, and it needs a lot of high-risk features or a very specific history. Then you have your morbus Meniere's, which is probably overdiagnosed. A lot of these depends on the duration of their dizziness. This is where the duration might come in. Where dysarrhythmias is usually a few minutes to seconds, and the others might not be as long. A lot of patients that we see actually do have bradycardia, and this is the patient group where you want to do an ECG on and get a history that is more oriented towards syncope. For these patients, for the AVS patients, which are the ones that we're talking about mainly now, because we want to talk about the HINTS test, if they have spontaneous or gaze-evoked nystagmus, then you will do the HINTS test on these patients. On these patients, you will do this hallpike or your head roll test. And when we are putting these patients into categories, well, I mean, in my clinical experience, it can be quite hard sometimes to place the patient in the right category, whether or not they have nystagmus or not, while lying still. And sometimes, even though sometimes you have a classical history of a BPPV, but the patient is still having nystagmus at rest, even though they waited for 5 or 10 minutes. And with these patients, I would say either you go do the HINTS test, in which case it usually will be central, because the hits, if you do the head impulse test on a normal population, it will indicate central causation. So what I usually do is I will actually, in this gray area, if they still if they have a classical BPPV history, but they have a bit of nystagmus left when I'm testing them with Frenzel's after they've been waiting for 5 or 10 minutes staying still, then I will use a this hallpike or head roll test. And if the signal here is really clear, meaning that, well, they give me an obvious nystagmus that is classical nystagmus for BPPV, and we will get into that in the end of this lecture, what that means. Then I will be satisfied with them having BPPV and not having a stroke. But just to say that sometimes it can be hard, and sometimes you will have to do a BPPV test. I know that certain experts in this field, among other Peter Johns, an emergency physician from Canada, who has a great YouTube channel, he disapproves of this method. But in my experience, this is the better method. But just be cautious and know that different people have different opinions on this matter. When you cannot categorize a patient, if there's the absolute answer where if you have a patient who has spontaneous nystagmus or gaze-evoked nystagmus, well, then you will have to do the HINTS test on them, and then you will have to admit them, even though they have a really classical BPPV history. But I find that argument is hard to swallow if you can do a Dix hallpike or head roll test that is obviously pathological or obviously points towards a BPPV if the patient doesn't have BPPV in their background. Let's talk a bit more about this category, the AVS, which is the one that we want to consider using the HINTS test for if they have nystagmus. Okay, so that was the who are we going to do this HINTS test on. And now we'll go to how are we going to do the HINTS test. So the how is best learned bedside. And the next best thing for learning this thing bedside is, I think, checking out Peter Johns' YouTube channel. And he has a lot of great content, not just on the HINTS test, but on vertigo or Dizzyness in general. I think I agree with almost everything he says. And he's probably the one with the greatest content. Maybe besides Dr. Newman Toker, who has a homepage himself as well, where you can check out his videos as well. But check out some of these people's videos because these are the people who know what they're doing. I will instead focus on the pitfalls and the tricks I've learned by doing the HINTS exam. So the HINTS exam consists of 3 exams. There's the HIT, the head impulse test, there's the nystagmus test, and then there's the test of skew. And the letters of these are created so that it forms the HINTS test acronym. And it was originally coined by Dr. Newman Toker in the Kattah study from 2009, which we'll go into details about. So the HIT test, head impulse test, is this test where you have your patient's head, have them look at your nose, and then turn their head just slightly, just 10 or 15, maybe 20 degrees to one side, and then quickly move them towards the midline. You can do it while you go from the midline and out, but I have always used it like this. The nystagmus is tested by doing your normal H test, and this is where we usually do it by doing a Frenzel so that we can fixate the patient's gaze and maybe evoke some nystagmuses that you would not be able to see otherwise. It is important that the patient is not looking at the extremes, that they are looking at maybe 2/3 of the way towards the extreme of their view. So what I would do with the Frenzel test is that put on their goggles so that they're in the dark. Then you will take their hand and make them look at their thumb, and then you will move the thumb with your own hand back and forth until you get that 2/3 of the way to the lateral extremis of the eye, and that's because if you a lot of people will have a few nystagmus beats in the end. A few people will have more than just a few beats in the end of their in the extreme of their vision, and or in the extreme of their eye, and real nystagmus should be visible at the 2/3 mark. Okay, and then you'll do the test of skew, which is just a cover-uncover test. And I'll give you some of the tips for these tests in a minute. But in general, you just cover one of the eyes with a piece of cardboard or whatever with your hand. And then you will focus on the eye that is not covered and see if it goes up or down. Okay. All right. So the HINTS test can each of the 3 tests can either have a central or peripheral result, and I'll give you some tips on these. One of the first tips I'll give you is that don't do the HINTS test in the manner that is don't do the HIT first and then the N and then the TS. Do the nystagmus first, as when you see your patients, you will always need to assess whether or not they have nystagmus or not. Because if they don't have nystagmus, as we talked about, then you don't do the HIT. Then you don't do the HIT test or the test of skew. So do the nystagmus first. Then, before jumping into each of the tests, it's important to know that, well, in order for this HINTS test to be pointing towards a peripheral cause, you need all of the 3 tests to be peripheral, like pointing towards peripheral. If just one of them points towards central, then you cannot rule out stroke. And that's why it's really important that you choose your patients right, because as we will see in a minute, a normal or a head impulse test that is normal or doesn't have any catch-up saccade, that is something that we all have. But that doesn't mean that all of us have strokes. So you need to choose your patient with nystagmus and constant dizziness to be able to interpret a HINTS test. Okay. It's important also the terminology and what you write in your chart afterwards. The thing is here that the HINTS test, sometimes you see that, well, it's a HINTS test negative. Well, that doesn't really make sense, because I know kind of what you mean, but the HINTS test can either be central or peripheral. It's not negative or positive, because this is a positive finding and this is a positive finding. So a better terminology to use is whether or not it's pointing towards central or peripheral. And especially when you're doing your HIT test, it's important to say, well, it's because when it's quote unquote normal, then it points towards central. So it's just use the words central or peripheral, or say that there's no catch-up saccade indicating central cause in this patient group. Then the terminology chaos is usually solved. Okay, but let's check out these the features of each test. So when you have nystagmus, when you test your patient for nystagmus, the central patterns of nystagmus would be a patient with a vertical nystagmus or bidirectional nystagmus, meaning that when you look to the left, they have a nystagmus going to the left with a fast face going to the left, and when they look to the right, the nystagmus, the fast face of the nystagmus has changed direction, so it goes to the right. That's a bidirectional nystagmus, and that's pathological for that is indicative of a central pathological reason. Then you have your peripheral, and that would be a unidirectional nystagmus. And sometimes they will, usually, especially if they have vestibular neuritis, they will follow something called the Alexander's law, which is when you look towards let's say you have a nystagmus going to the right, then the more you look to the right, the more intense the nystagmus gets, and the more you look to the left, the less intense the nystagmus gets. But it's still a right-sided nystagmus, meaning that the fast face goes to the right. The fast face is just a bit slower when you look to the left than it is when you look to the right. Okay. Some of the tips for doing the nystagmus test is, well, use the Frenzel or the Bartel glasses. The patient must be lying still for a few minutes. And the nystagmus, as we talked about, should be 2/3 of the way to the extreme of the angle of the eye. And then be cautious of patients on alcohol, and some places they also list phenytoin, because there's a false positive bidirectional nystagmus in these patients often. The head impulse test is a normal test indicating a central cause. Would be that there's no catch-up saccade, meaning that it just looks like any other patient where you turn the head. Then you have the peripheral one where you have a catch-up saccade, and I encourage you to look at Peter Johns's videos to see what that looks like. And it's important if it's vestibular neuritis, then if you have a nystagmus towards the right, then you would think that you would what you suspect or expect is that you have a catch-up saccade when you move the head to the other side. So right-sided nystagmus or fast-faced nystagmus to the right. Then when you turn the head to the left or from the right to the left midline, then you will see that there's a catch-up saccade. Some of the tips here is that record a slow motion on phone, either on your phone or the patient's phone. Do the head impulse test where you turn the head towards the midline and not away from the midline. Do small movements, 50 or 10, 20 degrees, and do it fast. And as Jonathan Etlow sometimes talks about, do the test. What this actually does is it stresses the vestibular apparatus so that we see what we need to see. But if you don't do it fast enough, then you don't stress it enough. And he uses an analog about well, if you have a patient with cardiac trouble and you don't do a stress test, or you do the stress test where they're just walking, then you won't then you won't stress it hard enough to see what you need. So you really need to do this fast and then with small movements. You can do this random movement thing with the head where you kind of shift from one side to the other before doing the actual test. And this is just to keep the patient guessing. I do this to make them feel relaxed in their neck. As well, because often they stiffen up when you do the test. So these are just small tips about how to make the patient relaxed and how to get the best out of the test. Then you should use your biceps and triceps, not your hands, because you have you need big movements, or sorry, not big movements, but strong and fast movements. And then hold their head on their temporal lobe, not on their chin. So hold high up and not down below. Okay, then you come to the test of skew, and if it is to be either central, then it has to be vertical or diagonal. No skew or horizontal skew, as we see with strabismus, is not central. Okay, it's rarely the only finding, and you should always focus on one eye at a time when you're doing the test. So when you're covering one eye, you should focus on the eye not being covered, and then test that several times, and then do the other eye and test that several times. Then you have your, I'm sorry about the Danish here, but then you have your HINTS plus test, and I just wanted to mention this, that the plus is hearing loss. I usually think about it as gait as well, but hearing loss is the official one. And if you have hearing loss, then the central thing is the ICA stroke, and the peripheral one would be the labyrinthitis, or morbus Meniere's, but that's usually a different story. But if they come in during their attacks, then it might definitely be a Meniere's disease as well. All right, so far I have not figured out how to distinguish these if they don't have any specific findings of labyrinthitis, such as fever or inflammation on their blood samples and so on. So the experts say that we should err on the side of caution when there is hearing loss and dizziness. So probably you should consider admitting the patient for stroke workup, for an ICA stroke. And that is in general a great tip. Like, if in doubt, do a CT, and then admit them as a stroke patient. The CT is not specific, and it's not to find anything other than just so that you can load them with thrombol or acetylic salicylic acid, as you would with every stroke. But it's important to distinguish that the CT is not done to find anything. It's to make it safer to load them if you're handling them as stroke. And it's a quite low risk to just load them with acetylic salicylic acid and wait for an MRI 48 hours later. Then it's important to know that, well, certain medications like antihistamine and benzodiazepines, they will reduce your findings. And sometimes you can use this if their findings are really, really high amplitude. If they have high amplitude nystagmus and it's really hard to find out, then you can use benzodiazepines to reduce this nystagmus and make it a bit more visible, whether it's peripheral or central. But in general, you should not give the patient these drugs before you're examining them, and in general you should probably not give them these drugs at all, at least not beyond 3 days from their onset, because it might wreak havoc on, or they might delay their healing process, no matter what the dizziness causes. Okay, so just to sum up from the HINTS lecture here, what is important here? Well, who do we do the HINTS test on? The constant dizzy patient with nystagmus and no other neurological findings. And how? Well, I would encourage you to check out Peter John's YouTube channel to find out how in specific terms. But I've just given you some of the tips for the HINTS test and some of the common pitfalls and pearls. Okay, let's just do a quick evidence-based intermezzo. What I wanted to just show you here is that what leads up to me thinking that the HINTS test can be used in the emergency department. And this is the first study, the Kattah et al. A study that actually made where the HINTS test was coined. And so this will be in Danish, sorry, but I'll explain it in English. So the PCOS of this study was like this. So you had 101 patients, mostly from the emergency department, and all of these had AVS, as as I just told you before, what the definition of AVS is, and then they had one or more stroke risk factors, and they excluded anyone with previous vertigo and hearing loss. And then they would test it by a neuro-ophthalmologist, and they would put into a category of benign or dangerous, which is central or peripheral. And they did serial neurological examinations. They did MRI, and they looked if the course of the symptomatology would fit with stroke or vestibular neuritis. And they also did a caloric test, and their outcome was stroke. And what they found was, well, there was a high risk population. This, like 3/4 of them had stroke. But in this population, they did find that the HINTS test was 100% sensitive and specific for 96%. And they even found that, well, the MRI was falsely negative in 8 out of these 76 patients. And it became apparent that they had a stroke a few days later when they did a new MRI. So when the HINTS test was pointing towards central, they waited and did a new MRI and saw that, well, the HINTS test was right in the first place. There are some strengths with this study. It's a well done study, and they did a good follow up with lots of MRIs, and there are MRIs after, even on the negative ones, so that we knew that so that we could assess that some of them might have missed stroke in the first place. It's also from this study, among other, that we know that the sensitivity and specificity of the MRI is a bit lower in the first 48 hours. There was also the people doing the study was doing the HINTS test were blinded to the MRI results, and the HINTS test was not part of the examination or the definition of stroke. And that's good, because it's what's called incorporation bias, where this is one of the big biases in diagnostic studies. So some of the weaknesses in this study is that there's spectrum bias. This is and it was non-consecutively included. So you have a lot of patients. If we are to use this in our population in the emergency department, then we probably need to do it's probably capable of being applied in the emergency department, but we really need to take into account that this is done by experts in a high risk group. All right, so that takes us to this next study by Ohle, which is a meta-analysis. They included 5 studies where they took patients where they tested for HINTS. In 4 of the 5 studies, it was neurologists doing it, and in 1 of the 5 studies, it was a mixed group of 1 neuro-educated emergency physician and 2 neurologists. And they compared it to either CT or MRI, and the outcome was stroke again, and this was a meta-analysis. And this was the result. Well, as you see here, the sensitivity is quite the same. And this is Kerber. This is the study where there was only, this is a study where they have 1 emergency physician and 2 neurologists. The other ones with neurologists only. You see that the sensitivity is not that much different. It is the lowest one, but there's confidence intervals going over the other ones, so it's not necessarily significantly different than the others. And then you have your specificity, where it is significantly worse, the specificity of this Kerber study. So that's kind of, does that mean that emergency physicians are bad at doing this test? Well, I mean, when you look at the numbers at the face value, then, well, yeah, it does seem like that. But then again, it's only 1 emergency physician this. So I think the title of this paper is a bit, I mean, it's clickbait, because you can't, I mean, the only study looking at emergency physicians, they only had 1 emergency physician there, and the data that they pulled from that study, it's mixed. You cannot take the data from the emergency physician, it's mixed between like these three people, the two neurologists and the one emergency physician. So you actually don't know whether it was the emergency physician that was bad or worse at doing the HINTS test, or it was the others. And when it all comes down to it, it's only one person. So why would we generalize this result just from one person? So I believe that this conclusion is a bit premature. This systematic review and meta-analysis demonstrated that the HINTS examination performed by emergency physicians cannot in isolation rule out a central cause for vertigo in patients presenting with AVS. I think that is, well, emergency physicians, there's only one emergency physician doing this test as I read this paper. So I think it cannot be generalized like that as they imply here. I just wanted to show you their table. So ENT, neurologist, one, and emergency medicine physician. So yeah. So as Ken Milne usually say, when you look at a meta-analysis, then you should always think of the meta-analysis as an apple pie, and which apples do you want to use for an apple pie? A lot of meta-analyses do put in a lot of bad apples to inflate your numbers, so that their p-values or their significance becomes greater. Their statistic significance becomes greater, but when it's made with bad apples, then that doesn't ring true. It isn't, the result becomes bad. So you need to, when you have a meta-analysis, it's never better than the studies that it consists of. So, and this is the exact point in this study here. Not that this is a bad meta-analysis, but the conclusion is based on just one study. And if you dive down into it, if you just take it for face value, then you might think, well, emergency physicians shouldn't be doing this. But if you go down into the literature and go down into and analyze it, then you see that, well, it's only one emergency physician. Then, so I would say from this study, I would say, well, the sensitivity and specificity is quite good, actually, in all of the other neurologically driven exams. So this is just an outlier. We need more studies on this if we want to conclude whether or not we can do it in the emergency department. And from my experience, I don't see why neurologists necessarily should be better at this test than we are. In my experience, a lot of there are some neurologists that are really interested in this, and some that are not interested in this at all, and they think that this is ENT or not their area at all. So it really depends how you look at it. And I think most physicians would be able to learn this skill, will that being neurologists, emergency physicians, or something else. But there's some evidence that suggests that, well, emergency physicians, at least if they're not trained, then we can easily misapply the HINTS test. And that is certainly something that I've seen being done a lot in my department as well. So we need some kind of education in this, and as with any other test, we need to know when to apply it and how to apply it. And I don't see why we shouldn't be able to do this in the emergency department. I really don't. Then there's this third study, and this is the study from the Ohle meta-analysis that had one emergency physician in it. And I just wanted to show you how this was done. There's 272 non-consecutive included patients, from the majority of which came from the emergency department. It was AVS with nystagmus or a subjective balance problem, meaning that they included AVS with nystagmus and without nystagmus, but just subjective balance problems. That is important. Then they excluded a bunch of patients with MS and BPPV and the neurological deficits, which was good. And then they did their hints test. And these were 2 neuroorthologists and 1 emergency physician trained in vascular neurology. And they used differential, but it didn't really change their nystagmus classification. Then they did an MRI, and they compared it to an MRI, and they had an MRI-based definition with beyond 24 hours of symptoms of stroke. And what the results are here is that, well, 1 out of 29 of the MRIs were negative, 10% stroke rate in this population, also a high risk population, I would say. But this is the main result here. Like 20 of the 29 strokes were not found by the hints test. But what is important here is of the 9 that were missed, 7 of them were without nystagmus. So those should not have been included. Those should have been either worked up as a stroke or not being used the hints test on at all. So if you read, and I think Dr. Newman Toker actually comments on this Kerber article, has a small editorial in the bottom of their article, and when they recalculate the sensitivity, it's 90%. So I mean, I don't really know what to make of this. It's only done in 1 emergency physician who is qualified in vascular neurology, but does that mean that they actually know anything about the hints test or anything about the dizziness? I think there's a lot of like Scott Weingard's lecture called Resus Wankers. There's a lot of, well, just because your sign says that you're a specialist doesn't mean that you're especially good at that particular thing that you're doing. And this is a point being made by people who study expertise, like Gary Klein, a neuropsychologist, sorry, cognitive psychologist, and the notion that just because you're expert in one field, here being vascular neurology, does that mean really that you know anything about this specific test? Which, I mean, you don't really need that much vascular neurological knowledge to be able to perform this, but you do need some skills, and you need some knowledge about what to do and how to interpret it. I don't know. I really don't think this is impressive. I think the study was done well, but I don't think I think they missed the mark with not doing hints test on AVS with nystagmus. Doing the hints test on AVS without nystagmus, and then I guess generalizing or maybe not this study, but Ohle study. The Ohle meta-analysis, they use the study to generalize that emergency physicians cannot use or do the hints exam, or shouldn't do the hints exam, and I cannot follow that conclusion. Okay, then just 3 or 4 take-home messages about evidence-based medicine in general from these studies in journal. First of all, evidence-based medicine is this triad of patient preferences, which is often forgotten, and the best available evidence, which is what we just did the analysis of, and then the experience and the clinical state and circumstance of the patient. And what we sometimes forget is that the best available evidence, well, that is our tool. We get a tool with inclusion and exclusion criteria, but we forget that there's a huge amount of clinical experience going into this. How do we find this condition even though we do know the inclusion and exclusion criteria, then you cannot just algorithmically like get this information from the patients. You need to be skilled at communication and history taking and and examination to actually know whether this condition has arisen, or as Gary Klein talks about in one of his papers called "Can We Trust Best Practice?" The notion that we can apply a rule if this condition arises, apply that treatment, ignores the ability to judge whether the condition has arisen, because we do not just see the small patients where, or the small amount of patients where hints is indicated. We see the entire mountain in the emergency department, and to be able to tease out this is expertise, and it cannot be algorithmically based only. It has to, we have to know when to apply certain questions and how to interrogate our patients, and how to all I'm saying is we should be cautious of just thinking that evidence-based medicine and the results of evidence-based medicine can just be applied blindly to a population in the emergency department. We need to acknowledge the skill of emergency physicians being able to tease out these symptoms, so that from both ends of the spectrum, like from both the we can find the inclusion criteria of the patients, so that we can apply the right test. Another example is from, if you go into MedCalc and read up on the Wells score, then you'll see Dr. Wells in the bottom tells us that, well, the Wells score should not be applied to all patients with a chest, should be applied to certain patients with a chest, and dyspnea. And how to find these patients is something that is not necessarily taught anymore, because we think in boxes and not in nuances. One of my worries about this is, if we take the example of PE, well, if you take a PE 60 years ago, then the PE was with certain symptoms, and the illness script, like the classical symptoms, the classical illness script of any person looking at the PE would tell you that, well, it had these and these symptoms, and only certain patients with chest pain and only certain patients with this and this were to be examined. But the problem is that as time is moving on, and we have gotten the equivalent of electron microscopes in diagnostics, like we've gotten more and more advanced CT imaging, and we test people of less and less acuity, then we find a lot of people with baseline pulmonary embolism. This is a point made by Jerome Hoffman in his YouTube video on overdiagnosis. And also a point made by Gilbert Welch, a physician who has made a book about overdiagnosis and has a YouTube channel as well talking about overdiagnosis. Well, the illness script today of PE, as opposed to the illness script a lot of years ago, is different, and we are diluting by calling everything PE. We are diluting what needs to be worked up, and in the end, it will be everyone with a chest, because we can always find smaller and smaller PEs with a lot of patients. I've mentioned this discussion in a bit more detail in some of my other lectures, so I will refer you to that. I'll move on. So the other thing about evidence-based medicine is this. Anand Senti on EBM 2.0 has made this curve here, and Simon Carley from St. Emlyn's has also talked about, like, when do we need to change? What amount of evidence is enough for us to change? And here we see a diagram just depicting, well, acceptable certainty before change. How certain do we need to be? and what is the cost-benefit ratio. So imagine that you have a something that has a quite low cost-benefit ratio, like I would argue that the Hinds test have. Then you don't need that much evidence. We don't have RCTs. We don't have that great evidence in the Hinds test area. These are small studies, and we're extrapolating from a lot of the studies. But in general, I think we can use this as long as we just are aware that, well, if we so that we are allowed to just pull back, and we will pull back the entire thing if we find evidence of the contrary. Then there's this thing about, and you can read this on your own time, and I will suggest that you check out Ioannidis's. There's a podcast with him on the recommended dose, but John Ioannidis is this meta researcher, researching about research, and since 2005, where he published a study called I can't remember the right title right now, but it's most evidence is false, something like that. He became really popular, and he's made his career out of pointing out errors in our otherwise bulletproof logic about evidence-based medicine, and how much of it is just not well done studies. There is one, and one of his arguments in this podcast is that, well, if this avalanche of studies and a culture of we need to publish things, and it's only like publication bias, is only positive findings that gets out there and negative findings don't get out there, then we have this huge publication bias problem. And when that gets into guidelines, then we apply it in the clinic, and we actually don't know what we're, in a lot of ways we don't know what we're doing in a lot of areas. And Prasad has done a lot of studying on this area, Vinay Prasad, and he's coined the term medical reversal, that we sometimes, on a very low evidence base, get things into the clinic that didn't need to be there, and which is harming patients. But we only find out that it's harming patients many years afterwards, when non-pharmacological companies can actually do RCTs on it. Well, this is a side of evidence-based medicine that is important to understand, I think, and not just John Ioannidis, but also Jerome Hoffman, Jeannie Lenser. A lot of people are talking about this. Ben Goldacre, and please look. I'll try to do a video on these terms and these people at another time. But until then, try to look up this. One of the points from Ioannidis is that, well, when we get more and more specific evidence in more and more the branch specialties and branch specialties of the branch specialties, well, then at some point this becomes enormously expensive. And when we have evidence that is not very good, but it has manifested in our clinic, in our daily lives, and is really expensive, well, who is going to make studies that contradicts these areas? Well, nobody from this area is going to make studies on this area, because they probably have imposter syndrome about this area. They don't know enough, and they're not interested in this area. And the problem is that we don't have any regulation or how to deregulate, or not deregulate, but how to scale back some of these things that we that we apply in the clinic after some pilot studies showed significance. We need to be able to cut it off, and that's probably a hard thing because each of these area now has a patient group, a pharmacological area where who invest money in this area, and it becomes really hard to actually get rid of. And well, Jerome Hoffman often quotes Upton Sinclair that it's difficult to get a man to understand something when his salary depends on it. So we have a huge problem that these branches are getting bigger and bigger and bigger, and our healthcare system, like what actually is needed in the central bit, is not getting taken care of because all of the money will potentially go to some of the newer stuff that is less important for the majority of people and might not have any good evidence behind it. This is, of course, just talking in general terms, but please look at John Ioannidis' arguments about this, and then you'll be able to understand a bit better than my quite bad explanation here. Okay, the fourth and last point, just quickly about EBM, and in this context, is that, well, we can look at each of the study results in a Bayesian way. So if we think about the p-values of a study, if you think about the study as being a test of is the Hintz test a good test for AVS in determining the stroke? Well, then there is a p-value or a confidence interval attached to that, and that might be translated into a likelihood ratio of 5. If you want to know more about this way of Bayesian thinking about evidence-based results, then please check out Anand Senthil's evidence-based medicine 2.0 blog, and his podcast with, among other, Casey Parker on Broom Dogs. The thing is here that if we can both agree on that a study results and a study quality, but if we come from different places when we assess our pretest probability, well, then we can come to different conclusions depending on the study result. So someone who believes a lot in this is a Fagin's nomogram, so this is a lot and this is a bit less. So someone who believes a lot in the study, who's convinced like me about Hintz test, and they read the study, they will be even more convinced, and now they're certain about the effects of Hintz. But someone who's skeptical reads the same study and just becomes a bit more sure, but not that much. So this is the explanation of why we can agree on the results of a study, but depending on our pretest assessment of the area, we can get wildly different conclusions. And the guidelines may or may not be updated because of this. So if you want to know more about this, please check out Simon Carley's Base and Belief blog, which for me was eye-opening. Okay, moving on to the last bit of this lecture, which is BPPV. We have already talked about when we have our monosymptomatic dissipation. I told you that either you have this classical history and you don't have any nystagmus at rest, or you have a classical history and maybe a nystagmus at rest, where I suggest that if you do get a classical finding of BPPV, well, then it's probably BPPV and you can move on from that. So let's talk about BPPV, and that this suddenly becomes a really important test in the dizzy patient, not only because it can help us diagnose or not diagnose strokes, but it can help us. The patients are usually hugely thankful, and it's a good thing to be able to actually fix a patient in the emergency department, and this is an area where you actually can do that sometimes. Just to illustrate what I mean when I say that you can, by finding a BPPV, you can actually rule out a stroke. Ruling in by ruling out, as I tell you, as I call it sometimes. If you have one of these landscapes of diagnostics, as I call them, then you have your dizzy patient and this gray area patient where I'm not sure whether I should go with the AVS way or we should go with the BPPV. You have different differentials: BPPV, stroke, vestibular neuritis, and vestibular migraine. Well, if you do a BPPV test and it becomes positive, then because the sum of all your diagnostic differential diagnoses must be 100%, then you will increase, then by increasing one of them really well, then you will decrease the rest. So I do believe that you can do this, even though some experts in the area don't think you should do it. But so make up your own mind about this. But I do it in my practice, and there's not a lot of hard evidence about this either. If you want to know more about like the BPPV and how to do it and the tests, then I strongly encourage you to look up this. It's a guideline from 2017 where Jonathan Etlow has been a co-author, and it goes through everything BPPV. And a lot of my points and pictures will be coming from this article as well. Okay, so BPPV, we have two diagnostic tests. We have your Dix hallpike test, where you make your patient sit upright, and you then lie them quickly down on the bed with a slight 30-degree hyperextension of their neck, and before leaning them down, you will turn their head 45 degrees to one side, depending on which side you're testing. If you're testing your right side, then you will turn them to the right side. And this is testing for the posterior semicircular canal, but this is 80 to 85% of all patients with BPPV. You will also need to test the supine head roll test, which many of you probably aren't doing. I know I wasn't doing it before I knew about these things. I only heard about the Dix hallpike test, but this is like 10 or 15% of all BPPV, so you'll be missing some BPPVs if you don't do this as well. And this is a quite easy test to do. You just lie the patient flat on their back. Sometimes it's also with a maybe 10, 20 degrees head of the bed lean, and then you just turn their head first to the one side, and then to the first to one side, and just look at their eyes there. And then when they're done, go back to the neutral position, and then look to the left side. These are the two tests that we use for provocating this triggered event, which was the definition of the triggered episodic vestibular syndrome. Yeah. What we want to notice when we're doing this test is there latency? What is the duration of the test? Normally, BPPV will only last for 30 to 60 seconds, and will usually go up, and it will usually have a gradual onset, and then it will be full on, and then it will gradually dissipate again. There are certain kinds of BPPV are different. You have the classical is the canalith, but you also have the cupulith, which is a different kind of BPPV, and they can last longer and look a bit different as well. But we'll get into that. Then you'll notice whether there are subjective symptoms. Sometimes there are subjective symptoms without being objective symptoms, but and according to the article that I just showed you, this does not count as a BPPV. You need the objective symptoms, but it's good to know that both objective and subjective goes together when you're doing the test. The objective symptoms, what you want to know is especially the characteristics of the nystagmus, and you want to know the direction, and the direction is either apogeotropic or geotropic. Apogeotropic is the rarer one, where the nystagmus goes towards the sky, and the geotropic is where it goes towards the ground. Geo meaning ground, and tropic meaning an affinity to. So it has an affinity to go towards the ground, and apo would be the opposite of that. So opposite of going towards the ground, which is upwards. So you want to know that you want to notice the direction, and you also want to know which way is it going. Is it torsional or is it horizontal? The torsional one would be the posterior BPPV, and the horizontal one would be the lateral canal BPPV. And you can get these results. Either you have your posterior canalithiasis, which would be a torsional and usually vertical geotropic nystagmus. It's important to know that the vertical part of this is not at rest. It is when you're doing a provocative test, and that is something totally different. It does not indicate a central cause, in the same way as a spontaneous nystagmus, when you're not doing a provocative test, would if it's vertical. So then you have your lateral canalithiasis. And these will usually have a horizontal geotropic nystagmus, meaning beating towards the ground in a horizontal manner. And then you have your lateral cupulolithiasis, or also sometimes canalithiasis, but usually cupulolithiasis, and these will usually have a horizontal apogeotropic nystagmus. So I know there's a lot of new words here, and just to say, I'm no expert at this, but I think emergency physicians can become reasonably good at this by just knowing a little bit about this, and you can help your patients greatly. What actually matters is what kind of you want to know what kind of, if it's posterior or lateral, and if it's posterior, which is most common, then you'll do a specific test which we'll go into, called the EPLES. Sometimes you do see patients with bilateral BPPV. This is rare. Sometimes you do see some patients with downbeating nystagmus, and this vertical nystagmus should be upbeating. If it's downbeating, then it might indicate stroke, and you should consult a neurologist or an ENT doctor. And sometimes after the EPLES maneuver, because you will often do the EPLES maneuver in series with the posterior canalithiasis, then sometimes you might see that the crystals has gone into the lateral canal. This happens rarely, but not that uncommonly. Okay, so the interpretation of these tests. So you do your Dix-Hallpike test on the suspected BPPV patient. If you get a geotropic torsional nystagmus, then this is a posterior canalithiasis in the ear that is going towards the ground. So I'll do my Dix-Hallpike. I'll have my patient sitting, and I'll turn their head to the right. And when I lean them back, extending their head over the bed 30 degrees, then I'll look at their nystagmus, and I'll see that they have a torsional nystagmus that is going towards the ground, with the fast phase of the nystagmus going towards the ground, meaning that it's a geotropic nystagmus. And then I would like to see that it dissipates after at least 60 seconds. And if that is the case, then I'll do the EPLES right away. Sometimes you will see not a torsional nystagmus, but you will see a horizontal nystagmus. And if you see a horizontal nystagmus, then probably what you're seeing is a lateral canalithiasis, and you should go do the head roll test. And as is also the case if you see a apogeotropic nystagmus that is horizontal, then you should probably go do the head roll test. The head roll test, well, if you see a torsional component, then probably, like just as with the Dix-Hallpike test, then probably you actually seeing a crystal in a different canal, so you should go do the test for that specific canal. But the meat is here. If you have a geotropic nystagmus, usually this would be bilateral in the canalithiasis of the lateral semicircular canal, and the when it's bilateral, then it's kind of hard to distinguish which ear it is, but as a rule of thumb, they would usually say that the most symptomatic side will be the ear that is sick. So I have my patient lying flat on their back, and I'll turn their head to the right, and I'll see a geotropic nystagmus, like meaning a horizontal nystagmus going towards the ground with a fast face. And when I turn the patient to the left, I might have a slightly less severe nystagmus going towards the left. Going towards the ground, which would be left in this case. So and here I would say that it's the right ear that is sick, and I will do a maneuver for the right ear at that point. If, however, I do the same test and I see when I turn the head to the right that there is an apogeotropic nystagmus, that means going towards the sky, then and it's going towards the sky vigorously on the right, but not on when I turn it on the left, and then it's going less vigorously towards the sky. Then I will that suggests to me that it's the left ear that is sick. So the rule of thumb here is that when testing the lateral canal, the nystagmus, whether it's geotropic or apogeotropic, will go towards the sick ear. So an apogeotropic nystagmus, the nystagmus that is most severe, it will go towards the sick ear. So yeah. And this is where it gets into the leaves, and it can be a bit confusing, and sometimes these patients actually are more self-limiting, meaning that they will usually recover faster without doing anything to them than the posterior canal BPPV. But nonetheless, it's important to try to find out which ear it is, because you have a specific treatment for it. Okay, the treatments for BPPV in general are these. So in general, there's the repositioning maneuvers, which is fixing the signal problem. Then you always need to inform the patient the expected course, meaning this would usually be days to at least hours to days with acute symptoms, depending on whether you found the right ear and you can do a repositioning maneuver. Then usually it doesn't last that long, but they will usually feel themselves a bit off balance for weeks to sometimes months, and it's important to tell them that. Then the cause of BPPV is highly unknown. There are some correlation with diabetes and hypertension, and certain literature suggests that we at least think about this when we have a patient presenting with BPPV. We do know that age above 40 is a strong correlator for BPPV. And if you had previous BPPV, then there's some chance that you will relapse. What is also important to tell the patients is that there's a risk of falling, and this is something that we often neglect, but it's important, especially in the elderly who have BPPV and might be off balance for a long time. It's important to check out other causes of imbalance, like medications, and try to avoid this for all costs. And oftentimes you have to admit these patients for rehabilitation and so on, even though it's a quote-unquote relatively benign problem. Then if the elderly patient falls on their hip and fracture it, then they have a high mortality. So then we already talked about then the admission. There are certain central causes. If the money doesn't, if it isn't right, if you have the nystagmus pattern but it's not really right, it doesn't have this classical presentation and you don't have the classical findings, but the history is BPPV-ish, or it's more or less gray area, then as always, err on the side of caution. Consult your neurologist if they know about dizziness, or admit the patient with a stroke protocol, and see how it is in the morning. Then you have your rehabilitation maneuvers, and these should be as different from the repositioning maneuvers. The rehabilitation maneuvers, some of the popular ones are called Brand-Daraf. These are, this is more like physiotherapy, where you try to make the brain become normalized to the stimuli. And these are less effective than repositioning maneuvers. But sometimes you cannot do the repositioning maneuvers because of patient cannot do them, or they're too old to do them, or they have inflexibility or something like that, so that you can't do them. Well, then you might have to do these, and it's important for the patient to know that, well, you have to actually provoke your dizziness, no matter what kind of dizziness you have, because then your brain eventually will adapt. And that is what we do with these rehabilitation maneuvers. And there are some specific maneuvers, Brand-Daraf, for instance, but there was also just going out and doing things as you normally would. Then you have your medications, and in general, medications is, if they need to be used, it should only be used in the acute setting, meaning that in the first 3 days or so. And I rarely prescribe other than antiemetics for my patients, especially benzodiazepines and antihistamines. They will dull the brain. They will make the rehabilitation maneuvers, or the rehabilitation in general, less effective. It will make it prolongated. And that's usually what I tell the patient, that I would love to give them something that could just take it away, but the brain has to figure it out by itself. And if I try to give them any medication, then it will just take longer. So, and then it's always important to consider following up with an ENT or a private practice doctor, because even though we in the emergency department do this workup, then sometimes we miss things, or the BPPV was not correctly diagnosed, or the patient is still having trouble. So especially, I usually tell the patient, if they still have significant dizziness after a few days with these repositioning maneuvers, then I would strongly encourage them to go to their general practitioner. Or sometimes if I'm not too sure about which canal I'm testing, I send them home with a Brand-Daraf method, and then and then I'll get them and then I'll send them to an ENT doctor. And this picture just to show that, well, you have your semicircular canals. This is where the repositioning maneuvers works, because you will try to reposition your crystals so that they go out of the semicircular canals and into this hub again. And when they're in the canal, this creates a signal to the brain. So what we're trying to do here with the repositioning maneuvers is that we're trying to reduce the signal. What we're trying to do in the rehabilitation is that we're trying to not get rid of the signal, but just trying to adapt the brain to that signal. And where medication marked in red here, it has an opposite effect usually of that. It will make the patient's brain be less sharp to these adaptations, and make it take a bit longer. Okay, so why should we even bother doing repositioning maneuvers in the emergency department? I mean, isn't BPPV doesn't the B stand for benign? And what is our job description in the emergency department? It's not benign stuff. Well, I mean, there are certainly arguments that can be made that these tests sometimes are time consuming. I think with praxis they are not, but they are a bit time consuming. There's a learning curve of how to use them and how to interpret them, but I think that can be overcome as well. And yes, it is a benign diagnosis, but it's not that benign, especially not in the elderly who might be off balance for a long time. It's important actually to we should look at our task in the emergency department to not just the extremely time critical things, but also to avoid subacute complications of what we're doing. I think I've talked about this earlier in a lecture about numbers needed to treat equals 1, and please look that up if you wanted to know more. So the arguments for us learning these things is that it's much more effective than conservative management. And when I say much more effective, I cannot remember the numbers right now, but it's I mean, as compared to not finding the right canal and not doing the right tests on the right maneuvers, there's a huge difference. And the good thing is that for the EPLEs, for instance, the numbers needed to treat is 1 to 4. I mean, you don't have to treat them that much before they're fixed. That's almost no test or almost no treatment in our departments that our numbers needed to treat so low. So really, these are happy patients when you find the diagnosis and get them home without that major dizziness that they're feeling. There's virtually no complications with this if the patient can tolerate it, and you might reduce falls in the fall risk in the elderly, at least in the acute phase. Okay, so how do we treat these maneuvers, or how do we treat these? So if you have this hallpike, then you treatment for that. When you see a classic geotropic torsional nystagmus, then you'll do the EPLEs test, starting with the 6 side. There's also something called the Simon liberatory maneuver, or the Simon maneuver. I have never used this, but just so you know, this can also be used for this. And then you have your for your lateral canal. You have either your Goffoni or you have your barbecue roll, and I usually use the Goffoni, so that's the one I want to show you. And it's important to know that, well, there's a Goffoni for the geotropic and there's a Goffoni for the apogeotropic. And the lateral canal is much more difficult than the posterior. So this is the most common one, and if you just know this, I will be happy. And you know that, well, this is a lateral canal, and I'm not sure how to do this, but I'll send it to an ENT doctor. Then that's fine, I think, because this is like 85% of all the BPPV patients. So okay, so the EPLEs maneuver, how do we do that? Well, we usually it can be done in succession with the hallpike maneuver. So you lie your patient down. You see your nystagmus, and well, if your nystagmus goes towards the ground here and it's torsional, well, then you have a posterior canal BPPV on the right side. And what you want to do then is just move right on into the EPLEs, which the first picture here. This picture is the EPLEs maneuver's first step. So you go from here and then move the patient's head to the left, and then after that you will tell the patient. I usually tell my patients, well, look to your left shoulder and get up on your left side without moving your head position, and that looks like this when they get up on their side. And after that you can put them upright, and either with their legs outside of the bed or on the bed, depending on. I usually do it outside of the bed because that makes more sense when you're doing it here. But here's the description of this same thing I just went through. And there are small variations to this, but this is the general thing that I usually do. It's important that they are outside of the bed, meaning that they have a hyperextension of their head, maybe 20 to 30 degrees. And it's important that they stay on the side until the dizziness has absolved or is almost gone, because then in theory the stone or the crystal has stopped moving and it's in the position that we need it to be before moving to the next position. Okay, then you have your Goffoni's maneuver, and in this patient you might have, this patient has been lying down on their back, and when you move the patient's head to the right, you saw a geotropic nystagmus to the right. That means that when you then put them upright, you saw a geotropic. The strongest geotropic nystagmus was to the right. They might have had a small geotropic nystagmus to the left when you moved their head to the left, but the strongest was towards the sig ear, as the rule of thumb is. So the strongest geotropic nystagmus is where the sig ear is, or where you assume the sig ear is. So, and with this patient, this would be this ear. So what you do here is that you take your patient and then you pull them down, and then they will have to move their head 45 degrees so that their head is smack into the into the bed. And this looks really uncomfortable, and they have to hold this position for a couple of minutes, usually 1 or 2. And after that, then they will have to sit up. And usually, and there's a bit of variation here as well, but usually you'll go up with their head still in this position, and then they will have to turn their head once they're upright. Okay, so that's the Gaffoni maneuver. Then let's see the Gaffoni maneuver for an apogeotropic nystagmus. Okay, so just repeat. When you lie this patient down, and turn their head to the right during a head roll test, then they would have had a weak apogeotropic nystagmus when you turn their head to the right, but they would have a strong apogeotropic nystagmus when you turn their head to the left, meaning that the nystagmus points towards the sickest ear, or the sick ear, meaning that when you turn the head to the left and they have apogeotropic nystagmus, meaning that it beats upwards and it beats towards that ear, meaning that this is the sick ear. Okay, so when you have a sick ear here, then for this maneuver you will do the opposite. You will pull this patient's head into the floor like that, just as we just showed you. If you're in doubt, which I sometimes am, especially with the lateral canal, then you can have some options. At my hospital, we often give them the Brandariff rehab method, so that they don't get any repositioning maneuver, but they get this Brandariff rehab method, and then they have to do this, and then they have to follow up with an ENT doctor to be a bit more sure about what the diagnosis was and what kind of canal it was, or whether it was BPPV at all. You might consider giving them medications, because these patients will not be fixed right away, like the ones where we can do a repositioning maneuver. And you might have to admit them sometimes as well if they're elderly. And just to reiterate, it is better to do a specific maneuver for BPPV, but sometimes it's not possible to find out, and you don't have time or some other reason, and then you can do this instead. Okay, so in summary, we have a mountain of undifferentiated patients in the ED. What we want to do is that we want to sort out the dizzy plus patients, where you have stroke symptoms from the posterior circulation, and you also want to be really careful with the patients who cannot stand or sit, not just because of nausea, but because of maybe neurological causes. And it's important to do the truncal ataxia, making them sit and with their hands folded across themselves, and then see if they fall. Maybe if you just give them a small push. It's important to know that medical causes are a big part of dizziness. It's more than, in some studies, it's more than 50%, but it's around maybe 50 or 60%, depending on which study you look at. And some of them are dangerous. Some of them, especially if they're syncopes or they're dyspneic or they have chest pain, then you think of heart problems, dysarrhythmias, ACS, so on. If they have head or neck pain, then usually I would think of dissection, but subarachnoid hemorrhages and so on, certain intracranial pathologies can appear with dizziness as well, but you should not always look these up. But if you specifically have neck pain and someone who's really dizzy, then yes, I would definitely check out do a CT angiography, especially if they're young. And they are off, and they cannot walk on their own. If you have, I had a patient recently who had syncopized and did have a thunderclap headache when you really went into the history, but actually came in with dizziness and he was throwing up. So syncope and the ECG showed T wave negativizations, inversions. And it was kind of like, well, you could go different ways with this patient, and sometimes it's not as clear as you would think. So you need to keep an eye out for these, and there can be other pathologies than stroke that are emergent. These more unspecific ones, which is usually when we don't find anything on a neurological exam, they can kind of stand, but they're a bit. These are usually the elderly patient. Maybe with the exception of anxiety-provoked dizziness, where you don't find a nystagmus, and where you don't find nystagmus at baseline, so you don't have AVS, and you don't find any gait instability, and you don't find any neurological examination findings, and you don't find any. You don't find if you do the hallpike test on them, if the history is a bit in that direction, and the head roll test, well, you don't find anything there either. Well, then usually what I think are these, like, is there anemia, is there hyponatremia, is there muscle wasting, is the balance problem, polyneuropathy, or medication side effects. So and these are important things. Just to either follow up with the primary care physician or admit them if they cannot stand or walk, despite all of these benign findings. They don't feel that they can take care of themselves at home, even though they might be able to walk, kind of. So yeah, it's a very heterogeneous group, but this is the way that I would usually approach these patients. As I told you, it's important to make them lie still when they come, give them this package of ringers and antiemetics if they're really nauseous and really in a bad way. And especially if you don't have time for this, then give them this. And then consider these. Do your exam and focus on, especially on these questions, 2 questions, but there are different other ways of doing this, and I've talked about the titrate method from Jonathan Etlow. And then you can oftentimes put them into these 3 categories. I didn't mention this 4th category because it's usually really specific. It's maybe a diving accident, or they've just had a dive. These are special patients that usually we don't see in the ED, but they will come to a hyperbaric chamber or an ENT department. But I mean, if they have been diving, if they have been diving, then you should definitely be aware of that. And also here, these patients, the trigger might also be trauma. So you might have a post-commotio or post-concussion dizziness presenting after 3 or 4 days that doesn't have nystagmus, but has this triggered constant dizziness. And these, we see a lot of these patients, but they usually have a very specific history for those. The other ones, this one with nystagmus, we should do the HINTS test on. The constant dizziness that is spontaneous, it doesn't become better when you're lying still. These we should consider TIA, but that is rare. We should also consider dysrhythmias and morbus Meniere's, and in these, the triggered episodic vestibular syndrome. This is usually BPPV, but also think about orthostatism. Yeah, I think that is all I want to say. about this. This is my approach to the dizzy patient. It's not perfect, but I would love to hear in the comments what you think about it. And as I told you, I do, when the area is gray, when I'm not quite sure, I will try to elicit a very high signal response. If it's not classical, then I don't go with it. But if it's classical, if I do get a classical geotropic nystagmus torsional when I do this hallpike, well, then and I do a Epleys and they become much better after a few attempts, then I have the diagnosis and I don't have to think about strokes, I would think. But and this is usually with patients who are lying still 5 or 10 minutes, but they still have a bit of nystagmus. And please check out Peter John's videos for more on this, because he would say that they will never have nystagmus even after they've been lying still for a few minutes if they have BPPV. But in my experience, the cupulolithiasis, the patient presenting with lateral canal cupulolithiasis or something like, or similar, they can have nystagmus going on for a long time, even though like beyond the 60 seconds BPPV that we usually classically see. So, but let me know what you think about this, and be cautious of my advice on this. All right. If you want to read more, then please check out these studies, and I thank you all.